Good afternoon, everyone. Thank you for joining us for this lung cancer screening webinar for private payers. Our speaker today will be Dr. Ella Kazerouni. She's the chair of the ACR's Committee on Lung Cancer Screening. A couple of housekeeping items. If you have any issues with the audio during the call and you're listening via the speakers on your computer, try dialing in via the telephone, and that should work better. There will be time for questions and answers after the presentation, and this is being recorded, and the recording can be shared after the webinar. Dr. Kazerouni?
Good afternoon. My name is Ella Kazerouni. I'm a thoracic radiologist, and I chair the American College of Radiology's Lung Cancer Screening Committee. Today we'd like to review the importance of lung cancer screening and some of the payment aspects related to coverage decisions that have been made following the U.S. Preventative Services Task Force decision and subsequent CMS coverage decision. To begin with, I'm going to talk about the background of lung cancer screening CT and why lung cancer screening CT is important clinically. Katie, one quick question. My advanced arrow is not working. To get to the next slide.
Okay. Give it a try now.
Nope, it has stopped working.
Okay. Oh, there you go.
Thank you. So after reviewing some of the background around lung cancer screening CT is important, we're going to talk about the U.S. Preventative Services Task Force decision, and that triggers under the Affordable Care Act coverage requirements, the CMS coverage decision, and the elements of a CMS-required lung cancer screening registry, which is important to ensure that this new test is rolled out with attention to quality and safety as it's brought to patients at risk. Lung cancer is the leading cause of cancer death in the U.S. in both men and women. More people die from lung cancer annually than cancers of the breast, colon, and prostate gland combined. There is a large population at risk in the United States, predominantly due to cigarette smoking, with 85% of lung cancer attributed to cigarette smoking. If we look at some statistics, we can see both in men and women the high proportion of individuals who develop lung cancer. In the U.S., there are estimated to be about 60 million current smokers and about 30 million former smokers. Tobacco is the leading cause of preventable death and illness in the U.S., responsible for 1 in 5 deaths, of which the major cancer death is lung cancer, but also includes chronic obstructive pulmonary disease and ischemic heart disease, which are other things that we can find on a CT screening examination. The National Lung Screening Trial was a randomized controlled trial of over 50,000 individuals, half of which underwent low-dose CT screening. It showed a significant reduction in lung cancer mortality by 20% and a nearly 7% reduction in all-cause mortality. Roughly taken, it takes screening 320 individuals to save 1 from a lung cancer death. This 8-year trial was funded by our own National Institute of Health. In addition, the National Lung Screening Trial demonstrated that CT screening is cost-effective at approximately 81,000 quality-adjusted life years, noting that this figure would substantially change if the assumptions they made based on management recommendations at the time were to change. Based on the mortality reduction and the demonstration of cost-effectiveness, in December 2013, the U.S. Preventative Services Task Force updated its recommendation on screening for lung cancer. The USPSTF recommends annual screening for lung cancer with low-dose CT in adults aged 55 to 80 years who've had a 30-pack-year history of smoking and are either current smokers or those who have quit within the last 15 years. These are individuals at high risk for lung cancer. Screening should be discontinued if a person has not smoked for more than 15 years or develops a health problem that substantially limits their life expectancy and their ability or willingness to undergo lung cancer treatment. Importantly, the USPSTF gave it a grade B recommendation. A grade B indication by the USPSTF means there's either high certainty the net benefit is moderate, or moderate certainty the net benefit is moderate to substantial, and that the particular service should be offered or provided. In terms of the Patient Protection and Affordable Care Act, this requires private insurers to cover lung cancer screening without a copay, as this applies to all medical exams or procedures that have received a grade B or higher recommendation from the USPSTF. The Affordable Care Act does not specify Medicare's coverage decision. Following the USPSTF recommendation, Medicare went through its own process to develop a CMS coverage decision. It convened a public comment period, a MedCAC panel, posted a draft recommendation with additional public commentary, and then posted its final national coverage determination in February of 2015. Medicare coverage applies to individuals very similar to the USPSTF guidance, with one exception, and that is the upper bound of age. CMS's coverage decision applies to individuals aged 55 to 77, but is otherwise the same. We're going to be going through the details of what the CMS coverage decision is and its importance to a national lung cancer screening registry. The CMS coverage requirements include three components. They include facility criteria, beneficiary criteria, and interpreting radiologist criteria. Fundamentally, lung cancer screening is a public health recommendation. Since the coverage decision by Medicare and the USPSTF recommendation, a large number of programs have been coming online to deliver this needed service to high-risk patients. Medicare, CMS, requires participation in a CMS-approved registry to ensure high-quality, appropriate screening, maximizing the benefits and minimizing the potential harms. The greatest benefit of low-dose CT screening is reducing lung cancer mortality, but is also a teachable moment to improve smoking cessation and offer counseling. There are potential harms to lung cancer screening CT that have been well vetted, and the registry requirement is important to track that we do not overestimate potential harms in these patients. Potential harms could be screening individuals who don't meet the appropriateness criteria, doing the test with unnecessarily high radiation exposure, making management recommendations leading to unnecessary diagnostic testing and procedures with potential procedure-related complications. By requiring that data is put into a national lung cancer screening registry, CMS hopes to show how lung cancer screening can be done in practice and validate that what has been done in research settings can indeed be done in general widespread practice. We're going to review the beneficiary eligibility criteria, the reading radiologist criteria, and the radiology imaging facility eligibility criteria for CMS. The beneficiary eligibility criteria are fundamentally individuals 55 to 77 years of age who are asymptomatic from evidence of lung cancer. They must have a tobacco smoking history of at least 30 pack years. A pack year is counted as one pack for 1 year. They must be either current smokers or individuals who have quit within the last 15 years. This does not apply to other forms of smoking, such as cigars. A written order for CMS coverage must meet the following criteria. Lung cancer screening, counseling, and shared decision-making should occur with patients at their first lung cancer screening recommendation and referral, as furnished by a physician or qualified non-physician. During a counseling and shared decision-making visit, determination of beneficiary eligibility should be made with respect to the criteria I've already described. Shared decision-making includes the use of one or more decision aids to describe and discuss the benefits and harms of screening, to set expectations about follow-up diagnostic testing if a screen is positive, and to discuss other things such as overdiagnosis, false positives, and radiation exposure. Counseling on the importance of adhering to annual low-dose CT screening is also included. As screening is not a one-time test, screening, similar to mammography, is an annual health maintenance and preventative service examination. What is shared decision-making? Fundamentally, shared decision-making is a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account not only the best scientific evidence and clinical guidelines, but the patient's own values and preferences. It honors the provider's expert knowledge, but also the patient's right to be fully informed of all their care options, potential harms, and benefits. This process provides patients with the support they need to make the best individualized care decisions while allowing providers to feel confident in the care that they are prescribing. An example of a shared decision aid can be found at this website. Should I Screen can be found at shouldiscreen.com. This is a web-based, publicly available, free shared decision-making aid with a risk calculator. Tools like this can allow patients to go through the information to see if lung cancer screening is right for them and to be counseled by the referring provider as to the benefits and risks in their particular healthcare scenario, taking into account other comorbidities that they may have. ShouldIScreen.com takes individuals through the benefits and harms of screening as required in the CMS coverage decision, as well as has an individual lung cancer risk calculator. The next elements are on counseling on the importance of maintaining cigarette smoking abstinence of former smokers and offering tobacco cessation for current smokers. This is to be offered at every lung cancer screening referral. If appropriate, when lung cancer screening is ordered, tobacco cessation intervention should also be ordered. Smoking cessation is a key element of any lung cancer screening program, as smoking cessation is the best way to reduce lung cancer risk. It's been shown to make lung cancer screening more cost-effective, and it improves health and reduces other leading causes of death, such as cardiovascular disease and COPD. There are many available resources to provide patients both on a national level from organizations like the American Cancer Society and the American Lung Association regarding smoking cessation, as well as in practices, health systems, and through state departments of health. I cannot reinforce enough how important smoking cessation is a part of every lung cancer screening program. Next are the reading radiologist eligibility criteria. These include board certification or eligibility with the American Board of Radiology or an equivalent organization, with documented training in diagnostic radiology and, importantly, radiation safety. It involves radiologists who supervised and interpreted at least 300 chest CT acquisitions over the last 3 years, and have documented participation in continuing medical education activities in accordance with the American College of Radiology standards. Lastly, they must furnish lung cancer screening with low-dose CT in a radiology imaging facility that meets the radiology imaging facility eligibility criteria, which I'll cover next. The imaging facility eligibility criteria include the following. Facilities must perform low-dose CT with volumetric CT using low-dose radiation exposures that are appropriate to patient size, meaning that dose may be lower for smaller patients and adjusted to be higher for larger patients in order to obtain appropriate diagnostic quality for these examinations. The second important one is that facilities must use a standardized lung nodule identification, classification, and reporting system. Facilities must make available smoking cessation interventions for current smokers, and they must collect and submit data to a CMS-approved registry for each low-dose CT lung cancer screening performed. The American College of Radiology has developed a practice parameter for lung cancer screening CT to facilitate, communicate, and educate to radiologists the criteria around which these CT examinations should be performed. In addition, the American Association of Physicists in Medicine has developed protocols across most of the makes and models of CT scanners in the U.S. today. These are free and publicly available low-dose CT protocols to make it easy for radiology practices to put one in place in their practice if they don't already have one. The protocols are set up for both small, average, and large-size patients, so we have appropriate radiation exposure for the appropriate size patient, minimizing dose and maximizing diagnostic quality for screening purposes. Key elements of a low-dose lung cancer screening CT protocol are that it should be able to be performed in one single breath hold using thin slices to get high diagnostic quality for finding potential lung cancers. The radiation dose must use low-dose technique adjusted to patient size, which typically requires a CT scanner of 16 detector rows or higher. With respect to using a standardized lung nodule identification classification reporting scheme, the American College of Radiology developed LungRads. This is modeled after the ACR's 20-year experience with BI-RADS, now in its 5th edition, which is the standard of care for the interpretation of mammograms and evaluating quality in mammography practices for interpreting radiologists. We've used the same structure in the LungRads interpretation scheme. This is fundamentally a structured reporting and management tool for lung cancer screening CT interpretation. In using LungRads, it facilitates practice audits and comparison of radiologists within and across practices as to the quality of their interpretations. This thereby facilitates quality improvement. The LungRads structure involves categorizing examinations with a numerical score of 0 through 4, the higher number categories representing the highest risk findings for lung cancer, as well as an important modifier S for other significant findings that can be seen on a chest CT. Chest CT scans have been used for several decades to look for abnormalities and evaluate them in the thorax, and we see many of these abnormalities on screening CTs incidentally, such as an aortic aneurysm, emphysema, severe coronary calcification, or mass lesions. The research has shown that by using LungRads, it reduces the positive screen rate that was seen in the major trial, the NLST, of about 1 in 4 down to 1 in 10, without missing significant cancers. This is important because it reduces the number of diagnostic tests and procedures performed between screens, not only making lung cancer screening even safer for patients, but further reducing costs and thereby improving cost effectiveness further. Using LungRads facilitates quality assurance and improvement in practices by setting benchmarks. At a high level, this is what LungRads looks like. We have examinations that are considered negative or have findings that are considered benign with a very low likelihood of becoming cancer, representing categories 1 and 2. Lesions that have a slightly higher chance of being malignancy, probably benign, but do require an interim check between screens. And category 4 lesions, which are the highest suspicion lesions, which require more aggressive intervention and testing. It's estimated that 90% of screens will fall into category of the National Lung Screening Trial's own database. As you can see, with each primary category, there is an attendant management recommendation. Since categories 1 and 2 are both considered negative screens, these individuals will be referred to continue annual low-dose screening in 12 months. Individuals with CT scored as category 3 would be recommended for an interim 6-month low-dose CT, and category 4A and 4B lesions, representing lesions of increasing size and likelihood of being cancer, would undergo additional testing on a faster interval. This allows the radiologist to report the examinations in a standardized manner and to give standard management recommendations, thereby making sure the appropriate recommendations are conveyed to the referring physicians, particularly primary care physicians, to facilitate the appropriate next steps for their patients. The imaging facility criteria also require participation in a CMS-approved registry. And to this end, the ACR has developed the ACR's Lung Cancer Screening Registry. The ACR Lung Cancer Screening Registry was approved by CMS as a qualified registry on March 5, 2015, and is the only CMS-approved registry to date. The ACR's registry is part of the suite of ACR National Radiology Database registries, which are designed to facilitate quality improvement programs and efforts and improve patient care by comparing facility data to others regionally and nationally. They are qualified by CMS as qualified clinical data registries for purposes of physician quality reporting systems. Such registries include the Dose Index Registry, the Colonography Registry, the National Mammography Database, and now the ACR's National Lung Screening Registry. The registry requires the minimum data elements that were included in the CMS coverage decision. These include information about the facility, radiologist, patient, and ordering practitioner identifiers. They include information about the CT scanner, the indication for the screening exam, confirming that there are no signs or symptoms of lung cancer, the patient is of the appropriate age, and smoking history. They include use of a lung nodule classification reporting scheme, which for ACR's registry would be LUNG-RADS. Includes documentation of smoking history, both pack years and whether they are current or former smokers. Includes fields for radiation exposure to track this as an important quality benchmark, and to know if the screening is a baseline screen or are subsequent annual screens. The ACR's Lung Cancer Screening Registry requires sites to input data on all patients screened at their facilities, not just CMS beneficiaries. We believe this is critically important to assess the quality of a lung screening program and to facilitate quality assurance and quality improvement. Social Security number is required as a patient identifier to facilitate patient outcome tracking as patients move across facilities. An individual might be screened at one site today, but move to another location for their follow-up testing or their next year's annual screen. Without a way to track patients across screening year to year, it will be very difficult to understand if screening CT being done in practice is at least as effective as what's been done in the research setting. Active participation in the ACR's lung cancer screening registry is also accepted by the American Board of Radiology for its diplomates participating in maintenance of certification, or MLC. In addition to requiring all of the CMS required fields, the ACR Lung Cancer Screening Registry requires outcomes at 12 months after a screening CT be tracked and entered into the registry. This includes information on diagnostic follow-up tests, whether they be imaging or tissue sampling of lung nodules or other thoracic abnormalities suspicious for lung cancer. It requires tissue diagnosis to be entered, specifically lung cancer diagnosis, including stage. In this way, we can track the true important outcomes of lung cancer screening, which include with respect to appropriateness and radiation dose, but also with respect to the outcome in terms of lung cancer diagnosis and ultimately mortality benefits. Additional risk factors for lung cancer may be entered into the registry but are considered optional. These are things such as radon, chemical exposures, or family history of lung cancer. The ACR Lung Cancer Screening Registry issues benchmark reports to facilities with information about the performance of the individual radiologists, which can be compared at the local, regional, and national level. Feedback reports include information on the appropriateness of exams performed at the facility, on the radiation exposure, including both small and large patients' radiation exposure to make sure it is appropriate. Information includes the distribution of lung RADS categories across the readers and the positive screen rate, the rate of diagnostic testing and sampling from tissue of patients screened at their center, and the lung cancer diagnosis rate for their facility. The ACR's registry was open for registration in the middle of 2015. To date, there are already 434 facilities entering data, which covers approximately 1,548 radiologists. Data on over 16,000 patients has already been entered into the registry, and the first benchmark reports have been issued. With that, I've taken you through some of the evidence behind why lung cancer screening with low-dose CT is so important to bring to patients, the coverage decision by Medicare, and the important criteria that they've put in place to make sure this can be done safely and effectively in practice with attention to quality, and that the important elements be included in practices such as tobacco cessation being offered and the use of shared decision-making. We hope this has been helpful to you in understanding the important elements of a lung cancer screening program and the quality aspects of performing these examinations. As I mentioned, the ACR registry requires that all individuals screened at a facility be entered into the registry, not simply patients who are covered by CMS. This may be important to you as private payers in particular about the performance of lung cancer screening in individuals who are covered by payment under your institutional practices. Thank you very much, and we'd be happy to answer any questions.
Thank you, Dr. Kazaruni. For the question, I'm going to go ahead and unmute the lines. Sorry about that. It's not letting me unmute all of the lines at the same time. If you have a question, please go ahead and either use the raise your hand icon, or you can type your questions into the question box on the webinar screen. And just wait one more minute, see if anybody has any questions. Again, you can use the raise your hand icon, or you can type a question into the question box. And I do see a question here. Hold on one moment. We do have a question about how many insurers are covering this. It actually, because it has is it A rating or B rating from the USPSTF, lung cancer screening is required to be covered by private payers. The purpose of this webinar was to explain to the payers the quality requirements imposed by CMS and how those can improve patient care.
I could also say we've audited our reimbursement here at the University of Michigan, where I practice, over the last year, and found that all of our private payers are covering lung cancer screening CT. Where there has been an occasional denial, we've worked with our private payers to understand the coverage requirements, and everything has actually been going quite smoothly with respect to reimbursement by private payers for our facility.
Are there any other questions? I think I see, let me see here. Anita, did you want to speak up?
I was just going to mention that there is a location on our website for the center designated list of centers, as well as the centers that are enrolled in the ACR's registry.
Thank you. Okay, I see another question here. Is there data to demonstrate how facilities are doing ranking compared to other hospitals in our region, state, or nationally?
That is an excellent question. As I mentioned, we've issued our first benchmark reports. I think with any new registry, it's important to make sure we understand the quality of the data that we are getting in. What I can say, looking at our first benchmark data, is that facilities are performing very well on the radiation dose metric with respect to delivering appropriate dose protocols to smaller and larger patients. That the appropriateness of screening is quite high, and it's too early to have sufficient data yet on patient outcomes because the registry only opened in the middle of last year, and it takes a full year before we can get the 12-month data collected for facilities that entered into the registry. So the early metrics, radiation exposure being appropriately low and adjusted to patient size, and the appropriate screening metric have been quite high.
Okay, and then another question. For the 3 to 6 month follow-up study, should patients be scanned with the screening protocol or with the diagnostic CT protocol?
Our recommendation is that the 3 and 6 months interim CT scans performed between screens also be done using a low-dose protocol. For purposes of coverage and payment, we understand that these are considered diagnostic CTs because they are based on the evaluation of a known abnormality and that they themselves are not screening examinations. But we do recommend the use of a low-dose protocol to minimize radiation exposure.
Great. I don't see any other questions typed in. Let me just make sure nobody else is raising their hand. Okay, I think that does it. If you do have additional questions after the webinar, you can email them to me, Keyesor, another Keysor @acr.org, and I'd be happy to get those to the right place. Thank you, Dr. Kazerouni, for your expertise, and thank you for attending. This is the end of the webinar.